Okay, thank you very much, Pat, for this introduction. I want to talk a little bit on quality of life issues and radiation therapy in head and neck cancer. Most of the studies addressing chemoradiation of locally advanced head and neck cancer report increased acute and in some instances also late morbidity. So the question is this a valid observation which can be supported by published literature results, and are the data sufficient to address this question? And so my brother did a survey on the different studies and looked with the concurrent chemoradiation, older studies first, you see here the different names, how it is with the acute toxicity and the difference in comparison, of course, with the control arm. And you see that with the drugs, we have here in a mean a 23.7% increase for acute morbidity, and some increase also, not in every study, for the late morbidity. Late morbidities have not really been reported in the older studies in a sufficient proportion. But when we look at the new ones with concurrent chemoradiation, you see also acute morbidity is increased about 16-17% in a big group of patients. And when looking here at the late morbidities reported, you see even here also, but here one study, Calais, just recently published, where there is an increase in late morbidity reported, and a mean value of about 8% of also increased late morbidity could be shown. And when you look now at the concurrent or alternating fractionation plus chemoradiation, Malano and others, where there is a reduction of the radiotherapy dose in the chemoradiation arm involved. You see this is, for instance, my study here, where we have a 10% less dose, total dose, in the radiation alone arm. You see also a reduction of acute effects and a little bit also of late effects. And when we put this all together and combine it with some other data from known small cell lung cancer, cervical and rectal cancer, you see a plot where we have the excess more than grade 3 or equal to grade 3 toxicity, acute toxicity, and late toxicity put together in this graph, we see no real correlation. So from the data available, we have not yet, I think, enough data available, and we have a big problem of reporting and defining the morbidities, the acute and the late morbidities, because we have so many different scores. And there I want to concentrate on in the rest of the talk, which I do on behalf of Andy Trotti. Andy Trotti, he's involved very much in reporting and the CTC 3.0 common toxicity score. And I will show you some of his data. And the target audience is, of course, mainly the investigator or the practitioner with an interest in the quality of life and toxicity, who wants to have a deeper understanding of toxicity profiles and quality of life outcomes, and research opportunities with that, and understand the role of quality of life and symptom tools and specific investigation of adverse effects. These are the educational objectives. And you see there has been published this in a special issue of the Seminars in Radiation Oncology, Adverse Effects of Cancer Treatment, Metrics, Management and Investigations, very recommendable issue of the journal. And how should we evaluate these adverse effects of cancer treatment on health status in oncology? So you see there are different items like a symptom item, an objective examination item, an analytic lab item, and the quality of life reporting. All this contributes to the common toxicity criteria. And when you look at the quality of life item, it's not the same as the toxicity item. Quality of life and symptoms scales are wholly subjective metrics, a highly individual personal perception, and the quality of life scores are affected by one's ability to cope or adapt to adversity, and also influenced by cancer status, and correlates with toxicity in some and in others not of the studies, and also may include diverse domains of social support, and may be complementary to and may help to inform the clinician, and is not a substitute, of course, for adverse event reporting. So quality of life is not so simple. And we have to have a balancing of the risk and benefit, efficacy on the one hand and safety on the other hand. And whereas for the efficacy we have well-developed endpoints and reporting methods, on the other hand, we have an underdeveloped issue for safety, and we have lacking standards there. And this gap constrains our ability to make informed judgments about the balance of risks and benefits. So there is a multi-step procedure when to come from terminology and grading system to toxicity profile, which is done by different steps, generation and capture, reporting and analysis. And when we go through it, we have also problems here, like, for instance, the variations in the grading systems. This is a very important issue. Or the variations in data collections practices, or the variations in reporting methods, and the lack of standards of summarizing methods, and this adds up to the deficiency in the safety reporting process, which may lead to underreporting and to bias. And so there were 4 initiatives started by this group, and the first one was to really modernize the CTC to the version 3.0. Second one was to develop a safety profiler, electronic data management of toxicities and reporting. Then the AERO adverse events reporting in oncology, and the last, which I want to go a little bit in it, is the TAME, treatment risk classification system. And TAME is a common understanding of toxicity burden. I will go in it a little bit later. I don't want to deal with this. I will skip it. And when you look at the development of the different system of adverse events grading system, you see really there is quite a development. The latest version was 1998, the CTC version 2, and we set together an international group of people and tried and developed, now it's published, the CTC adverse events version 3 for acute and late toxicity, and not only related to radiation late effects and acute effects, but a general terminology also for surgeons and for all the other disciplines. And this is the first comprehensive grading system for all modalities, as I told you already. So a comprehensive terminology. And it's not only a common toxicity criteria thing, but it's a common terminology criteria thing. And when we look here, we have graded 4 grading steps. A mild one, which is a little bit detailed here. A moderate, a severe, and life-threatening complications have been defined. And a whole... and this is the low risk and the high grade toxicities. And then we have a whole bundle of different symptoms as you can see here. No, a little later. Here the people are which were involved in the development of the head and neck module. And you see this is really an international gremium where you can see here 25 members. Perhaps I can show it once more. Yeah. No, it's running itself now. We have to go back, I think. Yeah, here, 25 members, 13 organizations, 7 countries, 6 cooperative groups, and so on and so on. So this is really a very comprehensive group of people, representatives of different organizations worldwide. So I think there is enough competence in it. And the aims were the protocol development and safety endpoint, data collection guidelines, and reporting standards. And here are the different, really, just as an example, for acute toxicity, the different items for late effects, for surgical effects. All that is included there. And now to tame the number 4 initiative of this whole issue. And this is a development of a concise adverse event summary and treatment risk classification system. And you see, this means, on the one hand, toxicity, acute toxicity. Then it means adverse late effects. Additionally, the mortality, so mortality from treatment, and the end results reporting. So this adds up to tame. And when you see now, come on, how tame is treatment, you see here the acute toxicity safety profile of RTOG 9003. And currently, what is done? A worst grade summary reporting, where the worst grade item is added up. And like this, you see only one of the items is really scored, and this is the highest grade item. And this T-score is an additional score which was introduced now. There you can introduce all the different items, even more than one, of course. And so the score means high-grade events in patient cohort versus patients in a patient cohort, the number of patients. And this T-score like this includes all acute CTC, grade 3 and 4 events for all toxicity items measured. And when you look what that means, in reality, for instance, here again, for these number of RTOG trials in head and neck entity, usually we see when we report as with the maximum score only a certain toxicity. When we now look at this T-score, we have a 5-fold increase, 500% difference in toxicity burden across the programs. And when you look at this for the increasing toxicity in the RTOG trials, this was the normal reporting, and this now is the additional, the new reporting. So the worst grade summary method has a 200% increase in high grade toxicity, and with a T-score we have a 500 increase. So we have a real addition in the high toxicity program. They appear less toxic by the systematic bias. And when you look at the RTOG 9111, you see that, for instance, in comparison with radiation alone, the acute toxicity is increased by about a factor 3 with the induction and with the concurrent chemoradiation, when you just change the mode of reporting and of scoring. And this is very important, I think, because when we look at the results in the literature, and we have always different scoring systems and reporting and analysis systems, we cannot compare the results at all. So this is so far to this. So the summary is the current safety reporting process has strengthened and limitations. The new CTC system is more specific and comprehensive, promising to provide more information-rich data, and current efficiencies may result in systematic underreporting of toxicities. and additional guidance and standards are needed. So I think this is very important for quality of life issues also. And at last, I would like just to mention the ARO 95-6 study, which we did, where we have an example how important it is to make real, hypotheses at the beginning of our study.